But yeah, thank you everyone for joining. We will be focusing today during our webinar on ethical considerations for medical care during a pandemic like COVID-19. I hope you all are staying safe and healthy wherever you are in the world. And I am Becca Sheehy. I'm the volunteer coordinator for MedGlobal. And today I am so pleased to be joined by Dr. Mike Drusano and Dr.
Hi, Greg. Yeah, my microphone's on. Don't worry.
Hi, Greg. Yeah, and Dr. Marin Gillis. We at MedGlobal are very excited to share this content with you and listen in on their conversation on ethics. As many of you guys know, probably MedGlobal is an international health and humanitarian organization. We are serving communities to provide them with sustainable, innovative, and free healthcare services around the world to populations such as refugees, displaced peoples, and other vulnerable populations. And so, yeah, we're gonna get started. If you do have any comments or questions, again, everyone, you can put those in the chat. I would like to introduce first Dr. Marin. She is the chief of the Division of Ethics and Humanities and Arts at Florida International University's College of Medicine. And she is joining us today from Florida. We're excited to have you here. And then we're also, if you want to say hello to everyone. And then we're also joined by Dr. Mike Drusano. He's an attending physician with experience in community health and complex humanitarian emergency response and education. He's also a MedGlobal volunteer. We've had him with us on several trips. And he was also an Ebola virus disease infection prevention and control officer in Uganda. So he's going to speak a little bit about his experience in that regard.
Thanks for the great introduction. I was also an Ebola first responder in Sierra Leone in 2015. And with MedGlobal, I've been to the refugee camps housing the Rohingya genocide survivors about 3 times now. And then I was also lead on one of the educational missions to Pakistan this past November. So it's great to be doing something else with MedGlobal today.
Yeah, thank you both for joining us. B, in the background, do you want to pop on the first poll that we have? If our attendees want to take a minute to fill out this poll, let us know a little bit about where you're coming from and what the COVID pandemic is looking like in your area and how it's affecting you. We'd love to hear from you, and then learn a little bit more about what your context looks like. But let me just turn it over to you, Dr. Mike and Dr. Marin, to move forward.
Okay. Thanks, Becca. Thanks for everything. So I think just to start off with, just like 2 disclaimers. Views here presented today are mine and Marin's, and otherwise stated they do not reflect those of MedGlobal, Florida International University, or any other organization or entity with which we are affiliated. And also, at times like this, we still encourage everyone to err on the side of caution, maintain social distancing, and follow all advice from your physician and public health authorities. And just view any claims made by random internet sources just with a healthy amount of polite skepticism. Okay.
Great.
So,
right. Mike, do you want to just give kind of an overview of the topics that you guys are going to speak about today, and then we can jump in?
Right. So we're going to divide it into 3 parts. I think, the first part, which I think is going to be more applicable to the broad audience, I think, or maybe just like broad population, is just like ethics of public health containment measures. Because they have been in the news recently. There was the big demonstration in Michigan, I think like 2 days ago, protesting just that. After that, we'll probably then move towards like healthcare workers, kind of like helping balance their sense of duty with their right to workplace safety, especially in light of the fact that our knowledge of COVID-19 is still just expanding day by day. So we really don't know the beast that we're working with. And then the third part, maybe the shortest, but sometimes these things tend to surprise you, is discussing, I guess, the allocation of resources and the ethics therein. Because we are hearing a lot of reports out of Italy, physicians having to decide who gets a vent and who doesn't. And yeah, there have been like guidelines that have been established. So.
Well, one of the things, like, thank you, everybody, for having me today. It's delightful. Like many people in my profession, anyway, we've been doing a lot of Zoom meetings, and this is by far the most enjoyable one the one that I've been looking forward to the most. And I think I'd just like to frame what's happening. Like, Mike and I were colleagues in Miami, and we kept in touch during on social media. And it was after Mike, I read an article that Mike had published on, was it Kevin MD?
Yeah, it's now gotten over 5,000 shares.
And so I reached out to Mike, like, personally on this, and we started a conversation about what he was talking about there. And as you can imagine, for people who are trained the way I am, a lot of people have been engaging us and asking us about things. And so what we're presenting to you today is basically just inviting you to the conversation that Mike and I have been having about this. And I mean, I am an educator, I'm a medical educator, and I can get didactic real fast. I've even got slides to bring up, and you're going to have to slow me down because I am an educator. But we wanted to make this less formal because these issues that we're talking about are very, very concerning. And they're not light at all. And what I really appreciate, and what I'd like to just thank you at Mike and all the people like Mike and all your organizations for all the amazing work that you've been doing, and how you've been putting yourself on the line for other people. And as an ethicist, that's where the rubber meets the road, right?
Well, thanks. It actually means a lot. And yeah, I think like MedGlobal, we've typically done a lot of work overseas, but I think now, given that like there have been obviously like structural issues in the United States that have been made very much apparent in recent weeks, we are kind of crafting somewhat of a response for a hospital in Chicago that takes care of mostly medically underserved people, and also helping provide PPE to them, but also to vulnerable populations elsewhere in the world. I know like Yemen is on the list, and I know they've reported their first case of COVID-19. So if you are out there, if you haven't done it yet, definitely like MedGlobal on Facebook, Instagram. I think we're on Twitter also. I don't have a Twitter account. Yeah, I try to stay at least like slightly sane with social media.
Well, and so like, I'm just going to dive right in now, like and I mean, like, I want to hear Mike's narrative about things, but basically just to keep in the back of your mind when we're talking about ethics and we're talking about like, big values and big principles, big ideas, what you see in any kind of public health crisis like we're having, or when the public are being asked to do things that they're not usually required to do, it's a tension between what we call like individual or autonomy rights, like my ability to be able to, respecting somebody's autonomy means that, I myself am the person for whom knows my own good the best. I should be able to make decisions for myself. I'm a rational being, I'm a rational agent. It's up to me, and this is respected. This is, for example, like this principle underlines and it's operationalized in healthcare and in health research by informed consent. Right? Like we get patients for informed consent, we get participants informed consent because we respect their autonomy, we respect their dignity and their ability of themselves to make decisions for themselves. So what you've got in the situation right now, for example, I mean, I've been like in Miami, we've been under like there's social distancing, there's I've been in place for a month. Yeah. Right? I mean, I go shopping and things like that. But so my liberty as an individual has been very curtailed. Right? So especially in places that value liberty, like, lots of places value liberty, and it's enshrined in one's governments, in one's constitutions, it rubs up against this idea, like of my individual rights. Like I should be able to go where I want. I should be able to shop where I want. And now I'm being told I can't do it. So the justification You see, so it's not like you can never do that, right? Because there's no absolute right of an individual to do whatever they want, right? I can't go and, you know, I don't want to say disgusting, horrible things, but, you know, there's limits to my freedoms. I'm not allowed to do what I want.
It's what Betty Bowers said in one video about the NRA, where she was just like, "What? No right is absolute. You have the right to practice your faith. You don't have the right to perform human sacrifice. Like, you have the right to free speech, but you don't have the right to commit slander or libel or like."
Right. So where are those limits?
Crowded theater. Yeah.
Right. So that's what we're talking about. We're talking about the limits. So it's not a question of whether or not the state, or, you know, just even talking about ethical obligations, not legal obligations, right? But is what's a justifiable limit, right? Like, what is it? Right. And so you've just given a whole bunch of examples, right? Like, one of them is when you're infringing on my liberty. Like, you know, let's say that you really want to come in my and so you can't do that. So there has to be a justification for this. And we've got a pandemic, right? You know, and like, so you can explain now, Mike, maybe people don't know, you know, why is it we're having social like, what's the justification?
Yeah, I think the justification is, and this is coming from somebody who was subjected to a very unjust quarantine after returning from West Africa 5 years ago. And I'll go into more about that. You know, I think that, and I had serious problems with my quarantine. I mean, like, I was constantly clashing with public health officials. Now I'll go over into the details why. But, you know, I think the difference between Ebola, where, like, you know, at least at that time, we had about like maybe 35 years worth of knowledge about it. You know, we've learned more in subsequent years about it, but, you know, we still had a good knowledge base about it. And COVID-19 is like I was mentioning earlier, there's so much that we don't know about COVID-19. And we are learning new things about it literally day by day. And you may even be able to say hour by hour. Our knowledge at the end of the day is different than like what the knowledge base, the knowledge bank that we had at the beginning. And so for that reason, especially given numerous cases of asymptomatic viral transmission, I think that one report out of Boston, where it was like a homeless shelter housing 350 people, everybody was swabbed. And some ridiculous percentage came back as positive, but it was like almost 150 of those who came back positive had zero symptoms whatsoever. And so, you know, I think at times like this, you definitely do have to err on the side of caution. And I think that, yes, it can be very difficult to do so, but much in the same way that you would do with your doctor in any clinical setting, I think like there is a certain amount of trust that you do have to be placing in your public health officials at this time.
Right, but the justification that you're getting to for why our liberty is being constrained, it has to do with safety. Yes, right? Correct. It has to do with safety for self and safety for others. And what's mitigating a lot of this is precisely that we don't have any reasonable way to determine how unsafe we really are.
Right, and that's the thing.
And no testing, right? So it's like, because of the way the disease it is, it's because of the test, like the people, we don't know how this thing is traveling.
And one of the basic tenets of epidemiology is that if you're not testing at all for something, then yes, the official prevalence is zero. And I know from just people that I've been speaking with in Miami, I'm still in contact with a lot of people there. And the things that they are telling me, like coming out of clinics, they're just like the case numbers that they are reporting is drastically underestimated. It's probably considerably higher. And yeah, I guess just for that reason, yeah, we really do have to undergo social distancing. We need to be listening to public health authorities. I mean, I could just talk about like my experience coming home from West Africa. There just seemed to be like so many things that were very like incongruent about it. And, you know, I think that, you know, in a lot of like the list of the stuff that you sent me, you know, the World Health Organization says that, yes, if you are going to be placing restrictions on human rights, it has to be like in pursuit of a legitimate objective of general interest. And it has to be strictly necessary. There has to be like no other less intrusive means available in order to like achieve the objective. And it has to be based on scientific evidence. And that was like my big problem with the health department in Florida 5 years ago. And I think also too, it needs to be justifiable, least restrictive as possible, and humane. And the thing was that it wasn't humane. And I think like maybe just going back to the beginning, we left Sierra Leone, we left on a commercial flight, we flew to Brussels, like some mega hub in Europe. And, we had a 6-hour transit there. And then we flew to Newark, also like another like major hub. And, my transit there was another 8 hours. And, it was perfectly fine. Me walking around like Brussels airport, Newark airport, I really seemed to be much of a threat until I was about to enter the state of Florida on a plane. And I just, at Newark airport, having several conversations with them over the phone, the tone I think that they had set off right away was not one of more concern. It really wasn't one of like evaluating how I was doing. It was more just like, well, like, you're back here now and you're presenting a clear and present threat and danger to public safety. And so we're here to constrain you, to keep you from doing that. And, I made it very clear to them. I was just like, look, like I have an MD, like you're scientists too. At the very least, you guys have a master's in public health. Like we need to be doing things by the science. And, they initially like at the airport told me, oh, well, no, like you have to call a friend to come pick you up. And like, I remember it was a Wednesday when I was arriving and I was just like, this is midweek. I'm not arriving at the airport. I'm not arriving at MIA until like close to midnight. I'm not going to ask a friend of mine to like, come pick me up at close to midnight and drive me home. And I just told them like, you have the resources. And if you think that this is so important, you're worried that much about contagion, then like, maybe you need to come pick me up and you need to come pick me up in a health department car. And I know that they exist. And, they said no, that they weren't going to do that the burden was on me to find somebody. And I'm just sitting here thinking like, no, like you're placing kind of a burden, a restriction on me. And so I think like it's reasonable to expect that maybe if you're exercising this burden upon me, that you at least like make this as easy as possible.
Well, I think that you're getting into something else that, I mean, as soon as we start talking, right, there's so many different things. And
we had a script, but we're probably not going to be sticking to it at this
I know, but you're bringing up reciprocity, right?
Mm-hmm.
And I mean, maybe that's like, it's time now to go into talking to like the second part, because this was about your article.
Yeah, I could briefly like just go over everything else, and then like we just like go in the concept of reciprocity. But I told them I was, they agree. I got home. They eventually like quote unquote allowed me to take a taxi home and not disturb a friend of mine. They called me before they were about to come over. They were going to take my temperature twice a day. They were going to interrogate me twice a day. So like where I had been, who I had been with. They initially though said that I wasn't allowed to leave my apartment whatsoever for 3 weeks for any reason. And what do you do before you leave for someplace for 7 weeks? You throw away all of the food that you had. I didn't have any food in my house. And I just said, you can't do this to me. I don't have any food. What am I going to do? And they literally said, that is not our problem. And when they came over the first time to take my temperature, they just said, well, we're not even going to come into your apartment because they're like, you're going to get us infected. And I was like, you can't infect somebody unless you're actively symptomatic. You have to come into contact with my secretions. And like, trust me, I'm not secreting anything. And secrete can be like, kind of like one of my favorite words in certain circumstances. But they just said, no, you have to come downstairs to the lobby. And are you going to be ashamed to do that? And I'm like, lady, no, I'm not going to be ashamed. Do you know why? Because I didn't do anything wrong. So I think there was a certain element of stigmatization to it. I felt that was really bothersome. I do have to confess the fact that like they allowed me to do it at home, I think was a lot more humane. It was contrast to what Chris Christie tried to do to Casey Hickox, who again was also just transiting through Newark Airport like me, but she was in transit on her way to Maine. She wasn't planning on staying in New Jersey. And he said, like, I'm gonna like do some political grandstanding here. So like, I'm going to take you into custody and you're not allowed to leave this confine that I've set up for you just outside the airport for 3 weeks. And yeah, I mean, like, maybe this is just like a side topic, but I think even the ACLU got involved with that. And I mean, I think a judge struck it down, and the judge's document, I think like decision, I mean, it was so scathing against like the state of New Jersey, they didn't even bother trying to appeal it. But yeah, I think that like just the way that it was done with them, there really wasn't, I even asked them, I was like, what is your justification? Why are you doing this? I was like, according to other guidelines, it says I am medium risk. I'm not high risk. It was like, yes, I handled the corpses of people that were deceased due to Ebola, but you know, I was in full PPE, which places me at medium risk, but they just said, no, this is the governor's order, you're high risk, even though the governor doesn't have a degree in biosciences. And so I think that was my issue. It just kind of contravened a lot of these documents from the United Nations that when you're instituting these, I guess, like public health measures, you know, like they need to be based on science. They need to be justifiable. They need to do it for the public good. I think you have to respect somebody's like human rights, human dignity. Telling me like you going without food for 3 weeks is not our problem. Like that's not right. This even went as high as my protestations, like went as high as the state office, the chief epidemiologist for the state of Florida. And, you know, I had to tell them, I was like, you guys are supposed to be scientists. You placed all these burdensome restrictions on me that have no basis on scientific evidence whatsoever. And that's a problem. And they were just like, we didn't place any burdensome restrictions on you. And I was just like, oh, but you did, you know, like, and, you know, I think maybe my whole point about this long spiel is that coming from somebody who had a unjust quarantine kind of placed upon him with restrictions that were very severe, even I agree with the measures that have been instituted, at least in the state of California. I mean, like pretty much like complete shelter in place unless you have to go to the grocery store or the pharmacy or you're an essential employee.
Well, because I think what you're saying is that it's a matter of degree. Like, you know, when we're talking about the liberties, like the constraints on one's liberty, right? That it's not either or. It's a matter of degree, and that degree, like how we make those regulations should be a matter of, you know, one, based on science, but number two, this is something that we should be talking about before an emergency.
Right.
You know, and this is something that's usually not done. And it's like, you know, everybody's running around in a panic, but, you know, these regulations exist. They're there in the world. People can debate them. People can talk about them and when we start to talk about things like rationing, you know, which nobody wants to talk about, isn't it better to do it beforehand?
Yeah, I think we do. I mean, there's lots of documents that are out there, and I think you shared a lot of them with me. A lot of them come from like the WHO. Sorry, not the United Nations. I may have said that earlier. I misspoke. But, you know, for some people who just like, for whatever reason, they don't seem to trust the WHO. And like, don't get me wrong. I mean, there's legitimate criticisms that like people can have about the WHO, but I mean, who else is there in order to provide this guidance? Effectively, nobody else. And I think you also provided me like, you know, guidance from like, you know, maybe not venerated, but like reasonably well-respected institutions here in the United States. Like the VA one, I felt like was very interesting as well.
Because I think another thing that you're talking about, and this is what I see a lot in the news and I see a lot with undergraduate students, is that people say, well, unless it's 100% for sure, that means it's not real. And what is 100% for sure? Right? I mean, death and taxes maybe, right? But, you know, there's nothing. So it's a question of reason, like probability and reasonability, right? And also it'll also show that we have to be vigilant, because if new facts come to light, then we might have to change our minds.
Precisely. And I think we're also just not even certain. We know about the course of the disease now, but we don't know what could be happening later on. For instance, you know, with measles, there is something that can happen years after infection, even minor infection with measles, called subacute sclerosing panencephalitis. I mean, just inflammation of the brain that eventually causes scarring, and it can happen out of nowhere after measles infection. So we don't even know like what the consequences of this disease are, like even down the line. Several years down the line, are people going to be having like somewhat of a measles type picture afterwards? And I think, you know, and I think in healthcare, a lot of it's almost like playing a game of chess. I think you always have to think like 2 or 3 steps ahead, like what could happen. And I think a lot of these measures that have been instituted by most states and localities are just for that, or just like, look, we need to keep our distance. Yes, we kind of have to shut things down for a while because we don't know what the long-term consequences of this are going to be, especially for vulnerable individuals. And so, yeah, like I have to hand it to like, you know, at least like the governors of like particularly socially responsible states like California, the other West Coast states, you know, like the states of the Northeast, Mid-Atlantic, Yeah, I have to confess, even coming from someone who was subjected to a very unjust quarantine, they have the right idea about things. And I think nobody likes it. But I think it was like what the president of Argentina best said, Alberto Fernandez. He said, I'm trying to think like how to translate this best into English. Pretty much it's a hell of a lot easier to reanimate an economy than it is to reanimate the dead.
Oh my goodness. Yeah. Oh my goodness.
Powerful. We've got a good question in the chat. They're asking, how does moral relativism factor into the global discussion on prolonged stay-at-home orders and social distancing rules? So could one of you speak on that, moral relativism?
Well,
that's a great question.
Well, I think that one of the things about moral relativism is a concept. I think what most people mean by that is moral pluralism, because moral relativism is the view that what's good for you is good for you and what's good for me is good for me, even if they absolutely and totally contradict each other. And I don't think that's what people are getting at with moral relativism. They're talking more about a plurality of views. And what we have in moral pluralism, in order for that view to even exist, you have to have a higher non-relative view that says we think that tolerance is a good thing, right? And if you think that tolerance is a good thing, that's got to stand regardless of what you think of sorry, there's just a little poll that came up on my screen. The absolute view that says that, you know, in all cases we should be tolerant of different points of view isn't relative. Right. So what I think this is so moral relativism is an idea, and there's lots written on this. It's what we're trying to do is to say we wanted to respect different points of view if they don't agree with ours. But I think that you're going to have to bite the bullet at some point in time and just say, okay, collectively, as human beings, we have certain sets of values, and people who studied this find that there are certain values historically and culturally that are absolutely, that are not relative. Like, and one of them includes a value of a human life. And so anyway, like this is a really, really, really big issue, and you just got me as a philosopher onto things, and I could talk about it for an hour. But I think what the questioner may be wanting to get to is, how do you justify different kinds of policies in different countries, or even within different states or different cities in different states in the United States anyway. And again, I think that, there's a difference between like what an individual may want to believe and what a policy should be for a group of individuals, right? Like, I mean, because we might not all agree on every particular moral issue or every particular policy, but that's different than how are we going to make a policy that's fair for the most people, right? And so then we have to collectively say, well, what are our values? And it does seem, like I say, that there is an almost absolute value, and that's the value of human life. And that if you assume that we're all equal with regard to our right to life, that each individual has intrinsic human value, we all have human dignity, that our lives count in the same way as human lives, then you've got to say, okay, well, how can we best maximize most of that given this unknown factor that we have, right? And what's the most reasonable way to do that, assuming we have those values? Because if you come from a value system that says, oh, well, I only value certain kinds of lives and not other kinds of lives, I don't think that people who have the belief that all life has inherent value and that each person has dignity, you have to entertain that. I think you get to say, no, well, you're wrong, right? So within that, my big thing is to say there's a distinction between what we might individually believe and then what a policy has to believe for, or what a policy has to be for a collective in order to maximize the values that we agree are the values of our collective. So
yeah, that's great. And to that point, from the poll, 98% of our attendees did say that COVID has been reported in their communities. So it is, this pandemic that we're in is something that is far-reaching. It's not isolated. It is present in almost everyone's lives in some way.
Yeah. Well, Mike, what do you want to, and this is why I've been dying to get you to talk about the article that you said had 5,000 hits.
Yeah.
Because this is a big one, and my medical students are concerned about it as well, because as most of us in medicine know, mid-March is when, the students have matched, they find out where they're going to be interns, and they're supposed to be graduating soon. And there's been calls, even some medical schools have even graduated their medical students early so that they can go into place, and go start to practice medicine. And we're delivering them into a very different world than, let's say, you went to after you matched in a hospital that you went to.
Yeah, absolutely. I mean, I think just to talk about the environment right now, and maybe about me a bit personally, they're just like, oh, you're just like one of these people that tends to like run to any crisis to help out. And so people are a bit surprised that I'm not there right now, like in the trenches in New York City. And I have like very conflicted feelings about this. I've expressed this and maybe this is like where we're going to be able to discuss reciprocity a bit more. And I think also just like a lot of like reasonable ethical considerations as delineated by the WHO. But from what I'm hearing in a lot of like doctors' Facebook groups, when it's a question of COVID-19, for doctors, they don't want to pay them. They're expected to volunteer. In the event that they are willing to pay them, they're not willing to give them hazard pay. They are reluctant to give them PPE. If they give them PPE, doctors are made to feel as if they should feel lucky to even have it. There's no protection from anything. So there's a lot of doctors out there that are being told to practice outside of their specialty. So pediatricians are being told they need to treat young adult patients. Like outpatient subspecialists are now being, because their offices have been shut down, have been recruited to do hospitalist medicine. But outside of New York State, nobody's willing to give physicians protection from medical malpractice during this time. And then on top of it too, there's no protection if somebody wants to be vindictive. They accuse a physician because they perceive physicians as having like, money on top of money on top of money, of suing a physician, accusing them of infecting them with COVID-19. There's no protection or immunity from that. There is no offer of providing no-cost medical care to physicians, like should they get sick with COVID-19. And even when there are these restrictions on PPE, like not being given enough PPE or being told you're not allowed to bring in your own NIOSH grade PPE, healthcare institutions are prohibiting it, and they're acting very vindictively towards clinicians who've chosen to speak out, doctors, nurses, and others. And so that's why I'm not responding to this. In West Africa, we had all of that. I was paid for my efforts. It wasn't, like lucrative, but it more than paid my student loans and expenses back home. We were given ample PPE. We were told that our safety was paramount. And on top of it too, if we got sick with anything, we were allowed to go home early. If we were diagnosed with Ebola, we were flown on private medevac, either the NIH or CDC or University of Nebraska, free of charge. Our treatment was free of charge. If we had inadvertently infected somebody else with Ebola, we were immune from any type of vexatious lawsuit or vindictive lawsuit. And on top of that, like in West Africa, like there's no such thing as MedNow. Okay, so I felt safe and secure going in. I was willing to do it because I think there was this recognition that I was providing a service. And so therefore that there was a degree of reciprocity. And, I would gladly join the fight if there could be like some reasonable assurance that I had like everything that was mentioned. And P.S., if you haven't supported the COVID-19 Pandemic Physicians Protection Act, you haven't called your representatives yet, you should. Just going to plug that, because that actually addresses the PPE and a lot of the issues like dealing with reciprocity. And yeah, I think maybe I would leave that up to you to maybe like describe reciprocity in like a more nuanced form, because it is detailed in documents like from the WHO and VA that I.
Right. So, I mean, this is because could you tell everybody what the title of your article is, or do you just generally, it doesn't have to be exact title, but you know, and I'll launch into it.
Yeah, I believe it's like the oath that we took. Written down.
Yeah, no, but I mean that's the point. It's about your oath, like the oath that you took didn't commit you to this.
Compromising our own safety.
Yeah,
and
right.
You were even having some of these, I guess, like maybe like lay people who aren't involved in healthcare, be like, oh, this is what you signed up for. I'm like, no, this isn't what I signed up
for. That's what I wanted to talk about, and that was the thing, and that's what I think gets to reciprocity, because a lot of people say, well, look at doctors took an oath, and nurses took an oath, and people in healthcare take an oath, and you're going, well, what does it mean to take an oath? And there's something that we call a duty to care. You know, that healthcare professionals have this thing called a duty to care. And it came up in situations when there'd be, like, let's say at the beginning of HIV/AIDS, like, you know, when this was going on and healthcare practitioners, like they didn't know about it. They didn't know what was going on. And you heard terrible stories of what was happening to patients, like, you know, that people wouldn't, like, they'd just be, like, the patients would just be put in dark corners, like in closets, nobody would attend to them. And they said, well, we don't have an obligation to this. So this idea of a duty to care came up. And so let's talk about this duty to care. And I think it again comes down to, look at, where are our ethical obligations? Like, you know, one of the things, like, because I'm interested in humanism and medicine, and a lot of people think that means, of course, which it does in part, talk about patients as human beings and treating patients as persons. But I also say that humanism and healthcare is a radical idea that providers are also human beings as well, right? And that, you know, providers are partners, they're parents, they're sons and daughters, they have all sorts of obligations as human beings, including the obligations that they have as being a professional healthcare provider. And so let's talk about that. So of the things that we say that, you know, the reason why healthcare providers have more duties than, let's say, a non-healthcare provider to respond in an emergency public health situation is because they're trained. Right? Like they have a specific knowledge set that lots of people don't have. Like that they have a competence in an area that makes them a professional versus a non-professional. This is precisely the kind of thing, Mike, that you're going on with, to say, look at, if you don't know what the evidence is, like, where's your degree? Right? You know, like, I mean, there is a certain knowledge base there that does entitle you to certain benefits. Like, you know, that your voice should count more in these kinds of situations than people who don't have it, but it also comes with obligations, right? But here's the question, like, where are those obligations absolute? And again, what obligation is absolute, right? So if you're saying, exactly, this is where the reciprocity comes in, right? It has to do with if you're requiring, you know, in the situation in the workplace, like either where the person is working or society as a whole, to call on their healthcare professionals because they took an oath and to say, you know, we've trained you, we've invested in you, you're the guys that have the privileges to all these different things, and we are obliging you to come. The reciprocity is that we, society, them, the hospitals that you're working in, have an obligation to keep you safe, right? So some people argue and they say, oh, does that mean that you're making a healthcare provider's life worth? No, right? And we can talk about that with rationing and with other things. No, what we're saying is that there are limits to it. And unless, like, let's just look at this. Unless you keep these people safe, because they have a specialized knowledge that not everybody has, especially in a pandemic that we don't know when it's going to last, you better treat these people well, right? Like, you better give them breaks. You better have a protective equipment for them. And if you are obliging them, like this is what the VA, right? You know, the VA document says, and we're going to feed you, and we better do things like make sure that you have rides to and from home, and we better make sure that your children are taken care of. So that's the reciprocity that I think that you were getting on about.
Yeah. And I think that, again, like I was saying earlier, in healthcare, we always need to think 2 or 3 steps ahead. And one thing that I said in my op-ed was that there were all of the, early on in the epidemic, there were all of these West African clinicians, doctors, nurses, they ran to the aid of their patients that were in extremis, because they just said, you know, forget this, my patient needs me right now. And they went in without proper PPE. Well, you know what? Eventually that patient died anyway. And then you know what? The clinician themselves got infected with Ebola. And now what we're seeing in the 3 West African countries, affected Guinea, Liberia, Sierra Leone, is that there's nobody around to take care of the same pressing healthcare issues that existed pre-Ebola. And on top of it too, you could argue that like a lot of the healthcare issues are even more acute, because during the Ebola crisis, you know, children weren't getting vaccinated, you know, like women weren't getting prenatal care, things like diabetes, hypertension weren't being treated. And so, you know, that had like longitudinal effects on those 3 societies' collective healthcare situations. And now what we're seeing right now is, because of the death of all of these local healthcare providers, is that, for instance, like maternal mortality rates in the 3 countries here today in 2020 are the same as what they were in like 1995 or 2000. They've had a steep regression. And so I think that if there isn't a certain amount of reciprocity, if there isn't a certain amount of just like inherent like protections granted to not just physicians and nurses, but like all clinicians, phlebotomists, respiratory therapists,
Absolutely,
you name it, like we're going to have a serious problem. And I think that's actually one thing that they're worried about in Italy. They had, I think like last week, their 100th doctor just succumbed to COVID-19. And it is one concern. They're just like, who is going to be left to be taking care of all these patients? And I do have to say, it's appalling how there's even, I think, like a certain amount of gaslighting from those in the healthcare industry. I don't like calling it an industry because it doesn't really produce anything. It doesn't make widgets. It doesn't make televisions. It doesn't make blenders. It's just like we provide a service. I think like we provide a service that pertains to an inherent human right. And I'm just going to go out and say that. But there was like one staffing company written by an anonymous doctor stating, oh, running in to take care of our patients, that's a duty of ours. It's part of our sacred calling as doctors. Running in to take care of them without appropriate PPE is part of our sacred calling. And like my jaw like didn't just fall, it like crashed the floor into a million pieces. I had to like super glue it back together and like rehinge it. I was like, the nerve, the absolute nerve of like just denigrating the lives of not just physicians, but
well, I think, and it's also, to me, I'm just saying, like, that's just, to me, like, it belies a gross misconceptualization, right? To say that you either run in and do absolutely everything all the time and risk your life, or you're do nothing.
right.
It's a matter, it's harder than that. It's not an either or, it's not binary. It's a matter of degree, right? And you have to think reasonably and use what? Clinical judgment, right? But to say, is this appropriate, is this not? And so what we have to do, though, is provide those people on the front lines who are having to make those crack clinical judgments, especially during triage, coherent guidelines, right, that are transparent, that are accountable, that are based on the values that we collectively as society and as a human, you know, that go to human rights, believe are the best possible things we can do. And that's the best we can do, right?
Yeah.
Because we all are going to make decisions under uncertainty, right? And you talked as well, I remember that one story you said where, you know, I knew that I could have saved this person under regular circumstances, but I had to put on my gear, you know, and that you carry that with you. And as a human being, I'm sure, you know, of course you do, but you also knew that you did the right thing.
I did the right, you know, I think the situation that I was in, I think at that time, I don't think any intervention would have helped. I think I'm just going to leave it at that.
Mm-hmm.
I will say that before we were going into the ETU, into the hot zone, that yes, we suited up. If we didn't have enough appropriate PPE, then we left people behind. It was just that then you just have to remain in the team room and you just carry on other essential activities. You mix ORS, oral rehydration solution, or like, you make like IV solutions, but like, you know, add potassium to these bottles of IV solutions. Like we had them doing other like necessary stuff. if we heard about stuff that went on inside the ETU in between rounds, and like those were very tightly regulated, 90 minutes only, twice per shift. Each shift was 8 hours. So everything was like very structured. We put on our PPE. We're very judicious about it. We went in with a buddy. And if at any time that there was a breach, meaning that a portion of our PPE fell off, you know, like sometimes you'd be just like holding a child or whatnot, like either giving them medicine or like trying to comfort them or like clean them up too, because Ebola, literally there's wet symptoms. I'll just leave it at that. You know, like what is it, a sick child too? Like they get really cranky and they just kind of bat at you, and they would like bat at our face shields, and our face shield would come off and just like, oh, like that's a breach. Like you need to leave. And like we would even police each other. It was just like, dude, like you just lost your face shield. Like you need to leave. Yes, I'll handle everything else, but like I have somebody else here with me. Like just go. And the population in West Africa, they're a noble population. They're a deserving population. You know, they got this like huge hit from Ebola after like 10 years of civil war, at least in like the case of Liberia and Sierra Leone. And so like I was glad to provide that service. But, you know, if like populations on the other side of the Atlantic, I feel are deserving, and healthcare workers working in those countries, both local and foreign, are deserving of these rights, of these regulations, of these protections. And healthcare providers here on this side of the Atlantic deserve it also. And I don't know why that doesn't make sense to so many people, especially healthcare administrators and just other people that are on the back end.
Well, it's a big question. And here I'm just looking at the time. We haven't even started to talk about what the what of the most, like, you know, there's ethics everywhere. That's one of the other things that I want to say, is that what I say to the students is that practicing medicine, it's not like you practice medicine and then there's ethics put on top of it. Like good medicine is ethical medicine. It goes together, you know, and so it's just been such a treat, Mike, to learn about your stories and to be able to have these conversations with you, because it shows that the kinds of things that we try to teach our medical students and our residents, it does matter, you know. And unfortunately, sometimes my students will say, oh my goodness, what did, you know, we talked about that once for 15 minutes in my first year, right?
Yeah.
But people like you live it.
Right. I mean, I don't know. My perception of medical ethics, at least in medical school, is just like, we're rejecting so much. Just, you know, my opinion like definitely changed over time, which is like why like we're speaking today, and like why I consider you to be a good friend too, and like why like you've provided me with guidance before. And I think also just kind of like validated a lot of the feelings that I have in regards to like not just what happened in West Africa, but like what's going on here today. And like I'll always be grateful for it. But, you know, I think like, yeah, people don't seem to realize that medical ethics, they really do imbue everything that we do in medicine. And it's always present, whether we're aware of it or we're not. And, you know, maybe you might roll your eyes a bit at medical ethicists, but you sure as hell are glad to have them there when you need them. And they do come up at times like this. And they even just come at times when there isn't a pandemic and just like critical care situations, I think. I mean, I think this might be like a good transition towards like the third part. But, you know, I think maybe just to end all of this, I think that like, you know, the WHO kind of like backs us up on like what we're saying, but I think even like a domestic institution, like the Veterans Healthcare Administration, the VA, backs us up too. And they do say that like, yes, that like at times of a pandemic, they wrote like one document in 2010 about influenza, if there's like a big influenza pandemic. They did say that like, yes, healthcare workers are entitled to pay. They're entitled to like all the protections that we just listed. They're even entitled to hazard pay, and that like, you should be using incentives to get people to come in instead of using threats. The WHO does say that like healthcare workers do have a duty, and provided that there is appropriate reciprocity, you are still obligated to show up. And if you don't show up, then yes, you are ethically subject to repercussions, which I think that you would agree on that.
Well, that would be a whole debate, you know, because I think just for the people who are talking about, it's one thing to say that a physician or a nurse or a respiratory therapist or an EMT person or a fire person, like a firefighter or a police officer in the same way, has like there's a job, but there's also a duty to respond. Like they don't have a choice, right? Like That's what we're talking about. And that's a bigger question, right? Because I think that's even a bigger question. We can't even get there yet when we're not even talking about that our providers are being given protective equipment. I mean, we don't even have to get to that big question yet to talk about the ethics of this.
I think the last part about this is like, we're always thinking about like longitudinality in medicine. I think the one ethical issue that I have, at least, or the issue that I have in the VA's ethical document is no death benefits, no disability or life insurance should a healthcare provider get sick. And it's like, well, if we're thinking longitudinally for society and for our patients, then I also think we need to think longitudinally for the people that are left behind, should there be healthcare worker deaths. And yeah, I guess maybe briefly we should just talk about like allocation of resources. I know like we're kind of like
just that little topic. Yeah.
Yeah, you guys have brought up a lot of great points. Let's do a couple of the Q&A questions that we have, and then I'll let you guys do closing remarks, and during that time, if there's anything on allocation of resources, let's do that. Awesome. Okay, so we've got a question. They ask, how do we ethically deal with the prospect that some folks can't stay at home, can't social distance? How do we repay their risks?
Well, I think that one of the things that this that most folks on in nations like the United States and in Canada and places like that are might be unaware of is precisely the inequities in society. And a lot of people don't know how close they are, for example, to to being worried about where your next meal is coming from, or be worried about your rent, until you have situations like this, like when all of a sudden, bam, I don't know what it was, the unemployment benefits applications, how they went up so quickly, in a minute, and because you realize how many people in the United States are so close to not being able to be financially sustainable, and we talk about the working poor, and that it really is a privilege to be able to shelter in place. It is a privilege to be able to say, oh, I'm going to Instacart my food, and oh dear, I have to wait for 2 weeks to get my, whatever, right? I mean, and it shows the inequity in society. And I think that this is a great big mirror for this country. I think that not every country has this, like Canada doesn't have the same thing, England doesn't have the same thing. And we have to really reflect, it's a time to reflect on it, because these inequities are there. Like, and why is it that in certain places like Detroit, it's the African-American population that's getting hit by this, completely in disproportion to how many African-Americans live in the community are getting COVID, and that's just a fact. And that reveals inequities. It reveals structural racism that are fundamental, and they always have been here. COVID didn't cause it.
COVID just further.
Yeah, we have someone asking exactly about that topic, about how could the disparity in the United States, specifically in the communities of color, fall under some form of moral muteness or veil of ignorance, is what they're asking.
I think that lots of like things like implicit bias, things that are invisible, things that don't touch people right away. It's referred to in literature sometimes, and I love this phrase of an empathy gap. That for some people, if it's something right in front of you, you're able to see it with your own eyes. But if it's not your lived experience, it's very difficult to imagine yourself there. And this moral imagination is what is another word for moral imagination is empathy. So I think that it's knowing people's stories and recognizing these stories will hopefully open people's eyes, because it's there and it's been there always.
Yeah, and then one other question, I think this is a great one to kind of wrap up what you guys were talking about in terms of those difficult duty of care decisions. The viewer is asking, due to those shortages of supplies and having to make the decisions about priority of care, how are we supposed to address moral distress and compassion fatigue in such a trying time? What is your guys' advice for that?
Mike, what do you do?
Oh boy. I don't know. Honestly speaking, I think I don't know. I never really reached out to anybody about my own particular scenarios. I think maybe I just took a look at it from the bigger picture, in that in West Africa, it was just a horrible, horrible situation. Maybe the only thing that we were going to be doing, the goal was just not to really make everything good again, but maybe to make everything less horrible. And I think that if you can kind of like take a look back and say that you did everything that you could to make things less horrible, then again, like, then that's what you have to look at. I think you have to take a look at the bigger picture too. And I think I said in my op-ed that, you know, I think some of the losses that I had in the Ebola treatment unit, one could reasonably say, well, they're counterbalanced by the fact that I'm still here alive today to be taking care of people now. And so maybe I think that's what one has to reflect on. I think you probably have to be dealing with those concepts once the dust is settled and once everything is over and you've had time to process it. I don't know if that answers the question.
Well, I think it does, but I also think that it's pointing out again the need for, with our healthcare workers, with all first responders, with our students as well when we're teaching them in medical school and in nursing school, to address this idea of moral distress and to recognize it, to name it, and then to bring forward, like to examine it. And I know that there are a lot of resources online if people were looking, and we can also put some together for you if you'd like, because we're doing it for our students right now and for our physicians and nurses. And there's, you know, there's therapies, but also just for all of us, I just want to bring up, because I am the director of ethics, humanities, and the arts, how at times like this for us to remember that it's usually now when we turn to the artists. And we turn to our musicians, and we turn to music, we turn to literature to try to make sense of these things. And that's why they're important to us.
Yeah, and we just had a really good article posted on our blog about tips for self-care and mental health for healthcare workers. B, if you want to post that in the chat as a resource for all of our viewers. One of the tips that was listed there was to remember to highlight the wins. So when there are successes in the difficulties, making sure to remember those and highlight those to help with that fatigue of the really challenging decisions that can often be more encompassing.
I think that's, you know, maybe like circling back to how do we deal with this moral distress. But yeah, you know, I do remember there was I had a lot of losses, I think, in the ETU. Despite my best efforts, despite the best efforts of my colleagues, they all worked really, really hard and sacrificed as well. There was one 12-year-old, I remember, he was just the worst stick. Nobody could get anything on him. And I managed to get, I think, a 20-gauge IV into the brachial vein. And I think that's how we were able to keep him hydrated, resuscitated. And even despite the disaster, I think that happened just one day during 15 minutes there, yes, that 12-year-old eventually did survive, and he lived to get out of the ETU. And even though both of his parents had died, he went to go live with an uncle. And I think maybe it's just, yeah, oftentimes at times like these, you're going to have a lot of loss. You're going to have a lot of disappointment. I think you're going to have to recognize it, do your best to process it, but like, don't forget about maybe the ones that you managed to pull out of the fire, I guess is the best way to put it.
Yeah, well, we're gonna wrap up really quickly. It's the top of the hour. As we're doing that, B, if you want to pop up the last survey question and take, if our viewers could take some time to complete that last poll. We want to thank everyone for joining us today. I know that you all are facing many challenges in your work as you are battling COVID, and so we want to acknowledge that and know that we are here to support you however we can. We also want to thank our panelists, so Dr. Mike and Dr. Marin, for both joining us. And one thing we'd love for each of you to consider doing is supporting our fellow healthcare workers around the globe. So MedGlobal is actively providing PPE in 6 different countries where there is a huge shortage. Places like Gaza, Syria, Yemen, Ecuador, Bangladesh. We're providing them with necessary equipment that unfortunately they are not able to access on their own, and are having to make these same sort of ethical decisions in really dire circumstances. So check out our website, medglobal.org, to learn more and support how you can. And I'll turn it over to both of you for any encouraging words that you want to share with our viewers, or any closing remarks that you have.
Well, yeah, I would just concur. Yeah, find MedGlobal on social media, like them. I think MedGlobal is on most platforms. I would also say I'm going to plug again the COVID-19 Pandemic Physicians Protection Act. It doesn't even just cover physicians, but all healthcare workers, the CPPPA. There's a change.org petition out there, already over 200,000 signatories on it. So sign it if you haven't already. Contact your representative in Congress and your 2 senators voicing your support for it. And yes, yours truly wrote the section about PPE. And it was great to have you all here with us today.
Yeah, Dr. Marin, anything you want to say?
I just want to thank again MedGlobal for putting this on, and for the people that I've met while we've been putting this together. It's been a pleasure meeting you. And again, thank you for all the work that you do.
Yeah. Thank you both so much. It's been an amazing conversation listening in. And we have some resources that Dr. Marin and Dr. Mike put together. And so we will send those to you in email and make those available to you, so you're able to look more into details on what they've been presenting today. So thanks to all of you, and enjoy the rest of your day.
You do the same, Becca. Thanks for arranging this. And Marin, yes, I got a bottle of champagne, just like you recommended.
Okay, great. I'll beat you later.
You guys are amazing. Thanks for spending some time with us.
No, thank you for having us.
Have a good night.
You too.